So I'll introduce
Hi.
you now. Welcome.
Thank you.
So I think many of you will know Dr. Ed Jabbari. He's a clinical researcher at the UCL Queen Square Institute of Neurology and a specialist registrar at the National Hospital for Neurology and Neurosurgery. Since 2016, his research has focused on using genetics and fluid biomarkers to identify biological determinants of disease progression in PSP via funding from both PSPA and the Medical Research Council. And he's recently been named Junior Award Winner 2024 by the Movement Disorder Society. So congratulations on that, Ed. And that was for his abstract to their Congress entitled Combined Application of Alpha-Synuclein and 4-Repeat Tau Seed Amplification Assays for the Differential Diagnosis of Parkinsonian Disorders. Voila, well, I will hand over to you now, Ed.
Thank you very much. I'll just share my screen. Just please confirm that you can see the slides.
Yes, we can. Thank you.
Fantastic. Well, thank you very much for the introduction and also the invitation to speak today. So I'm going to be talking today about these seed amplification assays, and it's a bit of a mouthful. So from now on, I'm going to refer to them as SAA, just to keep things simple. And this is a really exciting new potential way that we can diagnose Parkinsonian disorders, including PSP. So I'm going to talk about what I've been doing with this particular technique. So to begin with, to understand how this particular technique works, we just need a brief refresher on the neuropathology of Parkinson's disease and PSP. So when I say neuropathology, I'm talking about what's going on in the brain of someone who has PSP or Parkinson's disease. And pathologically, they are two very distinct disorders. So we know that in Parkinson's disease, the pathological hallmark of what's going on in the brain is a buildup of Lewy body pathology. So in this diagram here, I think you can see my cursor. Can you see my cursor moving?
Yes.
And fantastic. So this pink blob that you can see here is a Lewy body. And this Lewy body essentially is made up of pathologically misfolded alpha-synuclein protein. Okay, so we all have alpha-synuclein protein in our brain cells, but for various reasons in Parkinson's disease, this alpha-synuclein becomes more sticky, misfolded, and it clumps together. And when it clumps together, it forms these pink blobs, Lewy bodies, within the brain cells that then causes those brain cells to die. And that's a progressive problem that's ongoing that then leads to the symptoms and the progression of Parkinson's disease. Now, in contrast, in PSP and CBD, the pathological protein is 4-repeat tau. And again, we all have tau protein in our brains, but for various reasons, it becomes sticky and clumps together and forms these aggregates that we can see under the microscope at post-mortem. So it's 4-repeat tau protein that goes wrong in PSP and CBD. The other thing to mention is that actually what we know from various post-mortem studies of PSP is that actually up to 10 to 20% of PSP patients that come to post-mortem will also have coexisting secondary Lewy body co-pathology. So the primary pathology is still 4-repeat tau, but they also have Lewy body co-pathology that's existing alongside. And there's a lot of debate in the literature as to whether that co-pathology actually impacts on the clinical profile during life or how the disease progresses. So for now, that's something that's slightly debatable, should we say. But by and large, pathologically, we should consider Parkinson's disease and PSP as two distinct disorders. They're very different pathologically. But clinically, it's a very different story. So clinically, we know that Parkinson's disease and PSP look very, very similar, especially in the early stages of the disease course. And you can look at this through various lenses. So you can look at it via the campaign study. So this was a study from Cambridge where they took 239 patients with very early stage Parkinsonism who fulfilled diagnostic criteria for Parkinson's disease. And then they followed them up over time, and they found that up to 10% of those patients went on to have a revised diagnosis. And that 10% included patients with PSP and CBD. You can look at it the other way, which is that if you take patients with PSP and CBD who have a diagnosis of those conditions, and you ask them to look back, were you misdiagnosed with something else? The PSPA's own survey has found that up to 60% of people living with PSP and CBD were initially misdiagnosed. And you can be pretty sure that a majority of those misdiagnoses were patients that have been diagnosed with Parkinson's disease incorrectly. And our own work in the UK Prospect study, which again has been funded by the PSP Association, has shown that the diagnostic latency, so what we mean by this is the time taken from the beginning of symptoms to receiving a correct diagnosis of PSP, that diagnostic latency can be anywhere from 2.5 years to 4 years. So clearly, we should be doing better for our patients. That leads to a lot of diagnostic uncertainty. And it really highlights the need for a better objective test that can allow us to diagnose the condition much earlier in the disease course. So not only does it lead to diagnostic uncertainty for patients, but the other big problem that it leads to is for clinical trials. So in the latest large-scale international tau antibody trials for PSP patients, which unfortunately were negative, the average disease duration for a patient that entered this trial was 3.5 years, which again highlights this problems of delays in diagnosis. And of course, in a condition like PSP that we consider to be quite a fast progressing condition, if you're recruiting someone to a clinical trial who's already 3.5 years into their disease course, you're more than likely to have missed that therapeutic window where you may be able to achieve effective modification of the disease course with a drug that works. So this is something that we wrote about, to be mindful of the possibility that before we write off certain drug targets, we need to be mindful of the possibility that we could be delivering those drugs too late in the disease process. Again highlighting this unmet need for an objective diagnostic test that can diagnose the condition earlier on in the disease course. So that's the problem, and this is where I think the potential solution lies, the use of these seed amplification assays. So I'm going to briefly give an overview as to how these tests work, and then talk about the progress that we've made in this particular field. So I want you to cast your mind back to that first slide that I showed, which was the pathology of Parkinson's disease and PSP, and how one was alpha-synuclein Lewy body pathology in Parkinson's, and 4-repeat tau pathology being relevant for PSP and CBD. In both those proteins, the way they spread through the brain is, we refer to this as in a prion-like manner. So what that means is, if you have one brain cell, and that brain cell has pathologically accumulated tau protein, what that will do is that pathology will spread into a neighboring cell, which has normal tau protein, and it will, in essence, infect that normal tau protein in that neighboring cell to also become sticky and misfolded and clumping together to form these tau aggregates. And that's essentially how the pathology spreads through the brain, from cell to cell, from region to region in the brain, and that leads to the progression, the clinical progression of the condition. And essentially, it's that spread of the pathology that we're replicating in a test tube when we use these seed amplification assays. So I'll briefly explain what I mean by that. So in these tests, what you do is you take your patient's fluid sample. In this case, we're talking about spinal fluid. And that spinal fluid from that PSP patient will contain those pathologically accumulated misfolded tau protein. What you then do is that you add a recombinant man-made form of tau protein that is normal in structure. It's not misfolded, it's normal in structure. And by adding it to the patient's biofluid sample that contains those abnormal tau seeds, you then will cause the recombinant man-made normal form of the protein to become infected, and therefore that in itself will become misfolded and clumped together to form these aggregates. And you can measure the formation of those aggregates by adding a fluorescent dye called thioflavin T to your reaction mixture that allows you to actually measure the accumulation of those aggregates. So I'll explain what I'm saying by this diagram here, this graph that you can see. The lag phase is the initial phase where you're adding the recombinant man-made normal form of the protein to your patient's sample. You're mixing them together over a defined period of time. And as those aggregates form in your reaction mixture, you'll see a large increase in fluorescence that you can measure. And the increase in fluorescence tells you that your patient's biofluid sample contains those abnormal tau seeds, leading to the rise in aggregation. And if your patient's fluid sample doesn't contain those tau seeds, you will get no amplification. You'll get a flat line here. So it's a very good binary test that tells you whether it's positive or negative. So I hope that explanation has made sense. And
did have a question just about defining seed again. You may have done it, but can you just touch on that point once again?
So the seed is the abnormal accumulated protein that exists in your patient's fluid sample. That's the seed. And if that seed is present, it will cause the recombinant man-made form, the normal form of the protein, to become abnormal.
And it's adding it to the assay that is the seeding process, if you like.
Correct. So that seeding process that causes the man-made form of the protein to become abnormal is seeding, essentially. And the amplification part of seed amplification is this rise in the fluorescence that we can detect when those aggregates are forming in the reaction mixture. Okay. Now, there's been a great deal of interest in the development of these assays in the Parkinson's world, both commercially and on a research level. And this technology has developed really rapidly to the point where now in the US, they are proposing that these tests are used in the clinic as a diagnostic test for Parkinson's disease. So of course, we had a great deal of interest in developing an equivalent assay for the 4-repeat tau disorders, PSP and CBD. So thanks to a grant that I obtained from the PSP Association, almost exactly a year ago, I was able to travel here to Montana in the US. And this is the Rocky Mountain Laboratory, NIH Rocky Mountain Laboratories. And this is a laboratory that really have a great deal of expertise in the development of these seed amplification assays. And I worked in particular with Dr. Byron Coe and his team members, in particular, Dr. Christina Oru and Dr. Efrosini Artikis in these assays. And the purpose of this trip was twofold. One, it was to look at what would happen if we applied this alpha-synuclein seed amplification assay, this Parkinson's disease test, to PSP samples. What would the results be? And secondly, to work with them to develop the 4-repeat tau SAA. These were the samples that I took out with me to the US. We had Parkinson's disease samples. We had PSP and healthy control CSF samples from the Prospect study as well. So the first port of call was applying the alpha-synuclein, the Parkinson's disease test, to our Parkinson's disease and PSP CSF samples. And these are exactly the same plots that I showed you on the previous one. So you'll note, look at the middle plot here. this is the type of result that we had for a majority of our PSP samples, a completely flat line, indicating that there is the absence of Lewy body pathology, Parkinson's disease pathology in those CSF samples. And that's exactly what we would expect. In contrast, look at the top right-hand corner. This is an example of a clear positive result. And that's the result that we got in a majority of the Parkinson's disease samples. And then there was this really interesting subgroup. So look at these on the far right-hand side, the middle plot and the plot at the bottom right-hand corner. We found these results in a small subset of both Parkinson's disease and PSP samples. And this is telling us that it is positive, but it's positive with a very different profile to the unequivocally positive result in the top right-hand corner. And we refer to these weakly positive samples as having low and slow kinetics. Now, what I mean by that is that the maximum fluorescence signal is much lower in these samples compared to the true positives. And in terms of the time taken to reach that positivity, it's much, much slower. So you can appreciate in this sample here or in this sample here, it takes much longer to reach that threshold to call it a positive sample compared to this clearly positive sample in the top right. And what we found was that 15% of our PSP samples had these low and slow kinetics. And what our hypothesis is that this represents those 10 to 20% of PSP patients that I spoke about right at the beginning who have Lewy body co-pathology. Okay, so this is telling us that the test is really sensitive at picking up even low-level Lewy body co-pathology in PSP patients. But it tells us something else that's really important, and that's that to rely on just an alpha-synuclein SAA to diagnose Parkinson's disease is clearly not good enough, because if we're seeing positive results in PSP patients, that may then lead us into a false sense of security that that Parkinson's patient that we've diagnosed with PD is the correct diagnosis, whereas in fact it may be a PSP patient who has Lewy body co-pathology. So we're back to square one, where we're not effectively distinguishing Parkinson's from PSP. And this really highlights the need for a 4-repeat tau equivalent SAA. And that's the last part of the talk, what I'm going to talk about for the last 5 to 7 minutes, if I have time, Rowena. Do I have 5 to 7 minutes?
Yes, you do. And we've got a break afterwards. So if you've got a few more minutes, we'll be around.
Okay, so just lastly to talk about where we've got to with the 4-repeat tau SAA. So the first thing to say is that PSP and CBD are within a spectrum of tau-related disorders. And that spectrum includes other tau-related diseases, including Alzheimer's disease and Pick's disease, which is a form of frontotemporal dementia. So it's really important that when we're designing the 4-repeat tau seed amplification assay, that it is specific only to PSP and CBD. It doesn't give us positive results in those other tau-related disorders. So Dr. Coey's group at the Rocky Mountain Laboratories in the US had started working on this about 2 to 3 years ago. And they had some really promising results when they developed this 4-repeat tau SAA, and they applied it to brain tissue from PSP patients that had come to post-mortem. So you can see in the curves here for PSP patients, they were getting really clear positive results. And that was a really promising sign. But when I got to Montana and we tested this version of the assay, what we found actually was that the assay wasn't giving us reliable, reproducible results. So our first job was to modify this assay to make sure that it was giving us reliable results in PSP brain tissue. And that's exactly what we did with this modified version of the assay. So the first thing that I want to draw your attention to is on the far right-hand corner, which is AD, which is Alzheimer's disease, and PID, which is Pick's disease. And you can see that when we applied the assay to brain tissue samples from both those conditions, which remember are tau-related disorders, we get flat results. And that's exactly what we want, because we want this assay to only give us positive results in PSP and CBD. And that's what we got. So when we applied the assay to 6 brain tissue samples from PSP patients that had donated their brains to Queen Square Brain Bank, we got clear positives in all 6 of those samples. And this was reproducible when we repeated the experiments 2, 3, 4 times. So that's really reassuring. That's promising. We then applied the assay to 6 brain tissue samples from neurologically normal controls. So these are people that never experienced a neurological disorder, but they donated their brain at death to Queen Square Brain Bank. And in the first 5 of those samples, we saw clear negative results, okay, which is what we would expect. But then look at this sample at the bottom, that the 6th sample of a neurologically normal control was giving us positive results. And this worried us. This made us think that actually this assay is not working as well as we would have liked to have seen. So we asked our neuropathologist to go back and have a look at the brain of this person that had donated their brain to Queen Square Brain Bank. And lo and behold, what she found was the presence of low-level incidental PSP pathology in this person that had never manifested with symptoms. They had died before they had manifested symptoms of PSP. So this is a really intriguing finding, and it's telling us that the assays are exquisitely sensitive at picking up even really early low-level pathology that's occurring in the brain. But of course, the holy grail where we need to get to is the use of these assays in living CSF samples, spinal fluid samples from PSP patients. And that's exactly what we're working on at the moment, the optimization of these assays to be able to apply them to living samples from living PSP patients that allows us to diagnose the condition in the very earliest stage of the condition. And this is optimization work that we're doing at the moment. And hopefully in the coming weeks to months, we're going to be able to report on the final optimization of these assays that allows us to apply it to living samples from PSP and CBD patients.
Okay, and that was actually, I was just going to cut in and check. You're talking about PSP, but this is equally relevant to CBD.
Absolutely, exactly right. So initially, we've focused on PSP samples because we have more of those samples. But once the assay is fully optimized, we will, of course, be applying this to every single corticobasal syndrome sample that we have stored at UCL and also at our collaborators' labs as well within the Prospect network. So finally, just to wrap up the take-home messages and the ongoing and future work. So the alpha-synuclein SAA detects Parkinson's disease pathology. When using it in isolation, it's not enough to be used in clinical practice as a diagnostic test for Parkinson's disease, because we see that it shows positive results in a small subset of PSP patients as a marker of Lewy body co-pathology. So the future that I see is very much in the combination, the combined application of SAAs, an alpha-synuclein SAA with a 4-repeat tau SAA that will allow us to more accurately stratify patients as to who's got Parkinson's disease and who's got PSP or CBD at a very early disease stage. And this is something that is a real unmet need in both the clinical world and the research world. As I've touched on, 4-repeat tau SAA for PSP and CBD is in development, and watch this space. Hopefully, we're going to be able to report some positive results in the coming weeks and months. And finally, the last thing that I haven't had time to speak about is the prognostic value of these assays. Obviously, we're looking at things from a binary classification. Is something positive or negative from a diagnostic perspective? But the other area that I'm very interested in is, can we use these quantitative measures from the SAA, such as the lag phase, how quickly it takes for a sample to become positive, or how the maximum fluorescence signal, can those quantitative measures give us an idea as to how aggressive that seeding process is, and does that map into how aggressive the clinical disease course is. And the last thing that I want to show is some very promising results that we've obtained in the Parkinson's world, where we've found that the speed of how quickly a sample becomes positive is predictive of how quickly a Parkinson's disease patient will develop dementia. So I really do see that there is scope, when we do have an effective 4-repeat tau SAA, to use this not only as a diagnostic test, but also as a prognostic test that will not only be useful in the clinical setting, but also will be very useful in the way that we design clinical trials for PSP patients as well. So I've done a lot of talking. I hopefully haven't gone over time. I just want to acknowledge all of the wonderful colleagues and collaborators that I get to work with, not only at UCL, but across the UK and also internationally. And thank you very much for listening.
Thank you, Ed. Yes, it's exciting, the progress that's being made. I do have a couple of questions. Peter, I have seen some research that suggests a link between changes in gut biome and Lewy body. Could this be linked to PSP?
Yeah, that's a really good question. So that's been a very active area of interest in Parkinson's disease, and the rationale behind this is that we know that with Parkinson's disease, it's not just the motor problems like tremor or stiffness or problems with walking. There's a lot of non-motor symptoms as well, and these non-motor symptoms involve the gut. There's a lot of constipation in Parkinson's patients. Also mood and anxieties. That tells us it's not just the brain that's affected. And actually, what we know in Parkinson's disease is that if you take a sample of someone's gut, you will find those Lewy bodies within the gut. Now, in PSP, it's slightly different. It's considered less to be a peripheral and a brain disorder. It's more just a brain disorder. So there's been less interest in the gut and the microbiome. But it certainly could be a future area of research interest that is ignited by someone. But at the moment, it's not something that's being looked at in PSP in the way that it is in Parkinson's disease.
Thank you, Ed. That was very, very clear. Good. Well, we've got through everyone's questions. So many thanks for making the time to update us on the progress. It really does sound interesting and exciting. So we are now going to have a short break. The second half of the session is going to reconvene at 12 o'clock. So you've got 10 minutes to make yourself a cup of coffee or get yourself